Hey guys, Dr. Kyle Booth here at Elevate.
And I'm Dr. Zach Couples. I'm also at Elevate.
We're at Elevate. We got our second edition of Doc Talk. So we're going to be going over some common questions that we get about low back pain or just back pain in general. So we got a couple of questions on here, and they're honestly the most common things that we see. So we'll go through those questions, and then at the end, go through a couple of really basic common things that help with back pain that can be very helpful, especially in the acute phases, or like the very initial phases of your pain, just so you can start to kind of modulate that pain and start getting over it a little bit. So first question, why does my back hurt? Obviously we get that question a lot. We're trying to find a diagnosis, or trying to point towards one exact structure, or they want to know that they have a tendon or a muscle issue, but it's a good question, because most of the time we have to look at a functional scale, or we look at how they're operating, and then we give them more of a functional diagnosis. But first and foremost, they need to get evaluated.
Yeah, it's kind of one of those, all types of pain are really complex and involve a lot of different variables. For example, if you look at some of the statistics with back pain, some of the biggest risk factors for you experiencing back pain are if you have depression, if you have a negative work environment or a negative home environment. Those are three of the major things. And also too, in 80% of cases of low back pain, we cannot come up with a structural diagnosis, and that's MDs. So it makes it really complex and complicated to determine what the exact cause is. But fortunately, we have things available, as we'll talk about later, of when back pain becomes a serious issue that warrants a serious medical intervention. More often than not, even if the back pain is substantial, it can be something that we can help, or the course of time could also help.
Yeah. He highlighted something that's really important, is looking at pain as being what's called multifactorial. It has a lot of different entry points. It can be really truly mechanical. So you move in a poor way, and that causes pain. It could be emotional. Like you said, the work environment. It could be nutritional. It could be the things you're putting in your body. You have bad processes in your body, and you're not putting good fuel in your body. Man, that gets you really close to having pain, because you have inflammatory processes that are really high in your body. So making sure that you have someone that's going to evaluate and ask you questions about some of that stuff. So get evaluated by someone that's going to ask you multifactorial questions is pretty important. So make sure that if you get evaluated with that, someone is evaluating all portions of pain. It's not just your bone is this way or your muscle is this way. It has a lot more to do with the full body and the full human.
You are more than your back.
Yes. So another question is, when should I go to a doctor or an MD? This one's a really good one, because when we talked about how serious pain can get, or how debilitating it can get, that usually guides us to what we want to do. If you want to talk, about red flags?
Yeah. So the big things you want to watch for is if there's any issue with spinal cord is probably one of the biggest things, but there's specific symptoms that would signify you have an issue that is negatively impacting the spinal cord. And the main symptoms would be any loss of sensation in the genital region. If you have debilitating pain down your leg associated with weakness, oftentimes you'll hear what's called a foot drop, where you can't lift your foot up, like you're taking your foot off the gas. You're putting it on the gas at all times, despite your best efforts. If you have a loss of sensation in the leg, that would be another thing to worry about. And those are some of the big things.
I'm just off the top of my head, I'm thinking like if there was like an acute trauma. So if you had fallen and then you all of a sudden have this debilitating pain that's knocking you off your feet, or there's a risk of like a fracture or something internally. That's definitely a big one. He spoke about debilitating pain. So if we're looking at debilitating pain on my intake of a patient, I would make sure that I understand them and I hear them. They have a pain that's on a scale of 1 to 10, it's getting into the 8s, 9s, and 10s. I have a little bit more hesitancy in making a long-term treatment plan to get rid of that unless I see a trend that starts taking it away from those 8, 9s, and 10s pretty quickly. So most of the time with the initial intake, if I see that, I'm putting in the back of my mind that this might be a case where I need to send them out to an MD or send them somewhere that can maybe take that pain down a little bit. And they might be coming right back to us relatively quick, but we want to make sure we're checking our boxes off first. So we're making it a safe environment for the patient, and then we can get them moving as quickly as possible. But there's no point in skipping that step if it is going to be a quick referral. And then if you have someone that is on your team that can say, look, you're cleared to work with this pain, that's the best type of teammate.
Yeah.
Really, really good.
Yeah, I would agree. Also, too, if you just sustain the injury, and we're not talking about a traumatic event or any of the stuff that we've talked about before, realize there's a normal course of healing process that you're going to experience. And usually, if you have an initial injury, the inflammatory phase of the injury, when your body has swelling and it's throwing a bunch of good chemicals in the area to help the tissues heal.
Chemicals,
Yeah,
they don't feel good.
They don't feel good at all, but they are good. That lasts for about 3 to 7 days. So as soon as you hit back pain, even if it's really bad, still give yourself a little bit of time before making that call to go to the ER or go see your doctor.
Use the things that Zach was saying though. You know, if you have pain that's going to make your foot drop, if you have numbness, tingling, weakness in the genital region or into one of your extremities, one of your hands or your feet or anything like that away from the spine, that's a big one. But use those as tools to guide you. Okay, look, it's not wait and see, it's go get evaluated ASAP. That's really important, very, very important.
Changes in bowel and bladder function as well, that's another big
Yes.
one. If that happens, please go to the ER, please.
don't run to us, go to the ER.
Yeah, we're not going to help you with that.
We'll be expediting you right to
Yes.
the next provider.
Yep.
Okay, so and another question is going to be, should I get x-rays or MRIs or imaging done for back pain? So again, if we're working with a patient that they've watched this video and they said, oh, you know, I don't have the red flags or the numbness, tingling, weakness, and they show up and they say, you know, one of their questions are usually, should I go get an x-ray and MRI on this? Most commonly, we don't have to do that. Of course, if there's other exam findings that we get and it guides us to that, of course we're gonna send out for that. We are able to send out for X-ray, MRI. We don't do that within office, but we can send out to the people that we trust, and then we can get those imaging results back. But the most common patient that comes in that is very persistent about their back pain, most commonly don't need to have an X-ray and MRI done because, like Zach, he's going to talk a little bit about some stats on when those things are really needed.
Yeah, it's not going to change much of what we do if you are appropriate for us.
Mm-hmm.
If you don't have any of those red flags or the debilitating pain that we have mentioned before, it's not going to be our first line of defense. Consider this. If you look at people who do not have back pain and you take x-rays and MRIs of those people, depending on what study you read, somewhere between 30 and 80% of those people will have abnormal findings per imaging, meaning they're going to have disc bulges, they're going to have stenosis, they're going to have arthritis, things that you hear about with back pain that are scary. But that's in people who don't have pain. And I look at that two ways. One, we can't always correlate the findings that we have on X-ray and MRI with pain. Two, if you've already gotten imaging and you have those findings, there's no reason that you can't be in that asymptomatic category despite what the X-ray and MRI shows. Typically, if we have someone with red flags, we would send someone to go get that imaging, or if we work with someone for a few visits and we're just not getting the changes we'd like, perhaps it warrants getting that imaging. Because we're going to use that to let us know that we are not the person for you at this point in time. It could be a thing where you do have something on imaging and your symptoms in the clinic match that finding, And maybe you're not getting back surgery, but you could just be getting a cortisone shot or something like that to reduce the tissue inflammatory response, and then you're right back to us resuming your care.
Yeah, so, I mean, I can ask Zach this. How many times have you seen a patient that came in with a file saying, I have a disc herniation, and then you get them better within a frame of time, and you can't have a disc completely resolved during that time. So was the disc truly the pain generator? You know, like that I'm sure you've had plenty of cases like that. But those types of cases that come in, they have the stack of paper that says, you know, I have this and this, and it's been confirmed on X-ray or MRI, and then we see results. Tissue healing times can't always correlate, or they can't always be that quick. You know, so what else happens? There was other things that influenced that. It wasn't just this structural thing that was causing that pain. So keep that in mind. If you have a positive MRI or a positive X-ray and someone's told you have this diagnosis, it might not be the pain generator. There might be some other things that need to be evaluated, looking at movement, looking at how your body's functioning, and get a little bit better functional diagnosis and see if that can get you over the hump.
And with an MRI diagnosis, just because you had one physician say that you have X, Y, and Z on MRI, doesn't mean it's definitive. It's not an exact science. Consider this.
Very, very good stat here.
Yeah, there was a study done, and they took one MRI, and they had 10 different physicians, and I believe they were radiologists, look at the MRI. Guess how many diagnoses that person had? 35 different diagnoses among the 10 providers. I didn't even know you could have that many things wrong with your back. So it's not an exact science. Pain is not an exact science, and especially low back pain in particular. That doesn't mean that you can't get better, because there are a lot of ways, like establishing a functional diagnosis and addressing relevant impairments, that can make you better. But if you do have some findings that are on X-ray and MRI, it's not a death sentence.
It really isn't. Yeah, it's good. I forgot about that study that was done. That was an eye opener. We had a course come into town recently and went over a lot of those stats, and he went over that one specifically, and it was just like, man, there's so much variability in the body, and these pictures can't pick up everything. A picture is worth 1,000 words, but we need 1,000,000 words to really describe what's truly going on in the body. So another question is, you know, do I have back pain because I'm just getting old? You have to use that. This is a must. This is what Zach tells those patients sometimes.
Well, usually I'll say, well, your front is no older than your back, so how come your front don't hurt?
There it is. That's like, I mean, that's gold right there. But when we look at stats, so over the course of someone's life, 80% of people will experience low back pain at some time in their life. So it's not just because you're getting old. You know, there's definitely a correlation with a rising amount of pain during what years? Where was it? It was.
Back pain is going to peak in most people, or the incidence of back pain in the population total will peak around middle age, so 45 to 60. But if you look at image findings, there's a linear increase from starting at age 20 all the way until death do you part. Yeah. So another way to show that just because you are getting older, it doesn't always mean that that's the reason why you're going to be having back pain. Yeah. We grow like trees, and sometimes you get branches that grow kind of funky, but you can still get better, you can still move, and you can still function despite age.
Yeah. And when we get older, we have more responsibilities, we have more stresses, we have, you know, more things that are kind of put onto our plate. And when we're talking about, you know, depression and all the other things that can kind of come along as we get older and we get experienced more into our life, I think those things are a little bit more relevant, I'd say, most of the time.
Absolutely.
So yeah, that could peak through there when we have a little bit more responsibilities. So no, it's not just because you're getting old. There's a lot more factors that go into it. I love the line though. That's like, it's a perfect line for people. As your front is just the same, just as old as your back.
Yeah.
Real quick about medications, we have a lot of people that come to see physical medicine providers like Zach and I that are very against taking medications. They're trying everything they can to not take a medication. And sometimes I surprise people with my answer and I say, look, maybe on the front end we take something that's going to be low grade, like an ibuprofen or something that's going to kind of take some of the edge off. But at the same time, it can't just be that as the solution. We figure out, okay, we're going to add in medication, ibuprofen, whatever it is, and then we add supplemental movement on top of that. We figure out what they can't do well. We figure out how much we can push the envelope that gets their body processing and functioning a little bit better again. And so that's typically any of my suggestions, because I'm not an MD, it's going to be over-the-counter medications, ibuprofens, Advils, any of that stuff to take some of the edge off if needed. If they are at a low-grade pain level, something below a 6, I'm gonna try to have them not take some of that stuff, because I do think that medications is kind of like a crutch. Doesn't get us significant progress, and we definitely want the body to go through some inflammatory process, because that's what creates healing, and that's what gets nutrients to those areas. So very good if we're getting a low amount of those medications, then we have the thought process of cycling that stuff out. We definitely have an opioid crisis in America, so we've got to make sure that if we go the prescription route, that it's going to be effective, because I think some people get put on a prescription and they're like, yeah, I've been on this prescription for X amount of days, and I haven't really seen that much of a decrease in pain. And I'm thinking to myself, well, that might not be the best route for you if you've tried a trial of care with that and you haven't seen a result. Let's see if we can start backing some of that stuff off, not keep on increasing or adding more medication on top of that. Let's see if we can go a different route. So medications, they can be useful at some points. I'm not demonizing them by any means. Can get us out of holes. So that's for our medication questions. We can get to the next question.
Yeah. Another question we get commonly is, should I rest? Should I move? I need to chill because I just hurt my back. And I tell people the worst thing that you can do is nothing. If you look at overall research on recovery from back pain, generally the people who rested, didn't move much, and protected the area, it took significantly longer to return back to their normal everyday function. That being said, that doesn't mean you go guns a-blazing and you go do the things that you did before and push through pain and life is good. We want to meet somewhere in the middle. So if you've just hurt your back, you still want to move as much as you can. Perhaps break up your movement throughout the day. So if you normally go for an hour walk, but the thought of that increases your pain, you might just go for like short little walks around the house for 5 minutes at a time. Maybe just create gentle, slow movements of your back. Anything that's relatively pain-free. When people are trying to do movements when their back is hurting, I tell folks you want to think about pain as like a house, the house of pain perhaps. You want to knock on the door, right? But you don't want to bust down the door. You also don't want to play on the lawn. And that's a good way to think about how much you should move in relation to the pain that you're experiencing.
Absolutely. Like, we have to make sure that we're nudging, we're not blowing that door all the way open and kind of letting that inflammatory process go through its big cycles again. That's what we want to really, really decrease or kind of get away from. When we look at some of the most effective types of treatment for getting over back pain and getting through back pain is we look at the combination of what Zach and I are trying to do right now. We're trying to look at education. They need to understand what is going on with their body. So a really good thing that we talk about is like they're not good at certain movements, or they need to do this better. They need to figure out how to take the stress on. That's their education for it. We really try to to give our patients as much time as we possibly can to educate them so that they have a better understanding. Once you can understand something, it doesn't become so daunting, right? He's a whiz on the computer and he's got very good skills on that. That's super daunting to me. I would be very stressed out getting a task of having to program something on the computer. But once I understand it and I have the right resources, it's not as daunting. So make sure that when you are looking for how to get over something, you have as much understanding of the problem as possible. And then you have some movement that's going to aid that and get your body functioning a little bit better. So when we look at low back pain, that's what research is saying. It's saying looking at education and movement first, because that's going to give us the best result long term.
Be careful educating yourself though, because
Dr. Google.
Dr. Googel, as I believe he pronounces his name, is not
Terrifying.
So it's better if you have someone who is versed in back pain or anything guide you through the process. Just like you would probably learn a musical instrument faster if you had someone teaching you, or if you had this dedicated program that can take you through it. Same thing with getting over your pain. It's better if you have someone who's in the know guide you, as opposed to figuring it out on your own when you get bombarded with all this scary terminology that you don't know what it means, and then you see the pictures of the disc bulge and it's like this huge red thing in your back and it's scary. And
yeah, Google low back pain or Google disc bulge treatment or something like that, and you will get everything.
Yeah.
I mean, you will get a massive amount of things,
Yeah.
and everyone's different. Everyone's got to have a catered intervention, and even just the words that come out of Zach and I's mouth mean a lot different to each different patient. So things can get catastrophized. They can be really scared by saying certain names of diagnoses and stuff like that. So I think that's a really good point to drive home, is making sure that education is really sound, it's coming from good sources, and you seek out someone that's truly vested in your health and trying to get you as much education as possible. Don't get stuck in not knowing and getting treatment at the same time. You have to make sure that you understand why. That's a very big, and that's with anything in life though, right? You need to understand why you're doing it. So compliance will go higher. Anytime that I see a patient that hasn't maybe done some of the rehab stuff that I tell them, or their homework, I feel like I didn't educate them well enough. So I take that on myself and try to figure out how I can educate them better. It's really important for us. On the front end, I think Zach kind of talked about this. When we're looking at acute pain versus maybe getting out of that acute pain, movement's going to be a little bit lower, and you had a good acronym for this. It was NEATS, right?
Yep.
NEATS. What does that stand for?
It's non-exercise activity thermogenesis.
Write it down.
It's pretty neat.
So NEATS, just increasing, some of the activity that you have, so that your body's metabolic rates can start going up, and you can get some activities in your body that promote function, promote metabolism, promote everything that your body should do. So when we look at someone just kind of lying and being stagnant, not a lot of NEATS going on, right? They don't have enough neatness in their life. But that's a very good point, trying to increase that stuff. And then when we get past the acute stage, then we can start getting a little bit more specific, and we start nudging a little bit further into resistance type training, getting a little more load onto the body, and then increasing that way. So maybe some of the more important things, I guess I shouldn't say important things, but some things that people really want to get out of maybe our educational talks is what can they do? What are maybe the common things that they can do, and we have a couple of things. We're going to talk about what's called stacking, pelvic tilting, and then figuring out something that might feel good for you long term in terms of maybe a way that you move, and having that done repeatedly so you can start gaining more and more pliability with your spine. So we'll talk about stacking first.
With the stack, keep your line back and down. So a lot of times with, should be over here, a lot of times with back pain, if you look at research on this concept called movement variability, basically what that means is when you sustain pain or you have an injury, movement is restricted in the area that you hurt, right? Which makes sense. Think of it as if you broke your arm, what do you do to heal an arm break? You put it in a splint so the tissues heal. Your body has its own normal splinting mechanism. Good in the short term, not so good in the long term. Because, again, if you're not creating movement throughout your body, that's reducing circulation to the tissues, which makes things sore, stiff, and cranky. Teaching the stacked position is a great way to improve your movement capabilities, especially in the lower back region. So what we're going to do is we're basically going to stretch your low back from the bottom and the top. All right? So the way we're going to get the bottom position is I'm going to have Kyle bend his knees so you can line your back with your knees bent. And actually I might... Yep, you know, I work out. So the first part, and we're going to deep dive into this a little bit later, is creating a tucked position of the hips. So with this, you want to make sure that you're feeling your hamstrings and your glutes without any back tension in this position. You can either do it in this position, or for some people it might even be more comfortable to put your legs up on a chair or something like that, just like so. But for right now, because we don't have a chair, we're going to use this. So the cue that I like is, I want you to think about taking your belt buckle and pulling it, using your hips, towards your belly button. So just go ahead and curl your hips up, but your abs stay relaxed. You can go a little higher than that. Ideally, you want, if my hand is your tailbone and my arm is your lower back, you want the tailbone to move, not the low back. Which, Lucy, for tuning in, thanks. Curl up a little more, curl up a little more. Do you feel the back of your legs working?
I do.
Awesome. So you might just start with that so you get a sense of getting your body into that position.
And are you cueing people to actually drive their heels towards their bottom?
Bottom. Towards the rear? Not necessarily in this position. I'll do a heel dig if they can't get this tuck.
Cool.
All right? But you got it.
Yeah, absolutely.
So that's to get the bottom pull. To create the top pull, we're going to utilize breathing. Here's how I need you to breathe. Breathing is going to kick in the ab muscles. You're going to go in through your nose silently. Give me the longest exhale humanly possible. Awesome. And Kyle, do you feel your abs working? Try to keep that tension as you breathe in. Good. Go ahead and curl your hips up a little bit more. Awesome. You really want to make sure the exhale is super duper slow. That way you engage the deeper abdominal muscles. And usually I'll have people do 3, 4, 5 sets of 5 breaths, but for right now we'll just have probably that many breaths.
Yeah.
How was that?
That was good.
Awesome.
It was harder than it looks. You know, I'm not creating a lot of movement, but it's still difficult, very difficult.
Yeah. Many times people will, with just that little bit of movement, will shake, they'll sweat profusely, and if when you're done you get this whew sensation, you probably did it right.
Yeah. Cool. So he spoke a little bit about pelvic tilt, so on your Cupid. So just getting the body to understand the ranges of motion is pretty important. So if we can get the pelvis or kind of around the hips, if we can get that to rock forward and rock back, we understand what maybe hurts our back a little bit more too. So, so say we're having low back pain and we hurt every time we bend forward. So if we bend forward from the waist and we have that happen, if we rock our hips back, same thing kind of happens, but we're going at it very, very slow. There's not a lot of load here. You're not going to be forced by gravity to kind of get pulled forward. Now he has control of it. That's really important. So going through pelvic tilting with our patients, we figure out what really hurts, and then we can start, when we're talking about nudging into pain, not blowing the door open, we're getting back into those ranges of motion slowly. So just pelvic tilting, figuring out where your end ranges are, and then you start expanding that as you get less inflammatory process and you start recovering, your tissues start recovering and becoming less sensitive. That's when we can start increasing more and more flexion, more and more pelvic tilt, or anterior pelvic tilt, having the pelvis rock forward. In addition to that, when we are talking about maybe a position or a movement that makes things feel better, we're looking at what we would call directional preference if we're looking for something that is going to make the spine move, but we want to make the spine move under what's called passive load, or we're just going to let gravity take us here. So sometimes I'll have patients scoot your knees back a little bit. We're going to keep our arms locked out, and then during this, I'm just going to have the hips, let's scoot the knees back behind our hips a little bit more.
So you want to be like
yeah,
this.
so just something similar to this. So this might be a little bit more down the road, but then we're going to have the hips start shifting down towards the table and be as loose as possible. Let all of this be nice and loose and hang out into a little bit of extension. So once we have found that maybe we can get into as much extension as possible, now we just have a little bit of end range load so the body feels a little bit more comfortable finding that end range and beginning to accept load in those tissues again. So coming out of that and then repeating those ranges of motion, again, oscillating joints, getting a lot of fluctuation, a lot of tissues moving, and also circulation going through there. Really, really good for, again, helping movement start to happen again. So those are our 3 tips. So we got stacking being in a supine position, or lying on our back. I shouldn't say supine. That's not good for education. But lying on our back, making sure our back is supported, and then we have small movements with some really good core bracing and fundamental neutral spine, and then we figure out some graded movements for getting our pelvis to rock back and forth, and then finally getting into maybe some bigger movements where gravity's pushing us around a little bit, but where our body's accepting it a little bit more. Anything else to add?
Give it time, stay the course.
Give it time, like it doesn't have to be overnight.
And oftentimes it won't be. And if you look at the gamut of treatments that can be performed for low back pain, the old adage, time heals all wounds, is very true when it comes to low back pain. So this will get better, you will get better, so please be patient, give yourself time, do as much as you can on a daily basis, and that's going to allow you to progress over the long term.
Yeah, we're here to help nudge you along too. We have our treatments and we work with you guys in-house. We try to nudge you a little bit faster. We try to give you that guidance. So if you have any questions, reach out, comments. We'll get back to you if there's any comments. And stay safe out there. Hopefully this whole COVID thing's over as soon as possible.
Be safe, namaste.
See you guys
Later.